If you are a man over the age of 60 and you consistently wake up between 2 a.m. and 4 a.m., not at midnight, not at 5 a.m., but specifically in that 2-hour window in the middle of the night, I want you to pay very careful attention to what I am about to tell you. Because while many men assume that any nighttime waking is simply the result of an aging bladder or a full prostate, the specific timing of nocturnal awakening carries medical information that goes far beyond urinary function. The 2 a.m. to 4 a.m. window is a period of profound physiological activity in the aging male body, and the symptoms that emerge during this specific window, whether urinary urgency, anxious waking, racing thoughts, sweating, or simply the abrupt transition from sleep to wide-awake alertness, are in many cases the body's way of signaling that specific hormonal, cardiovascular, or neurological systems are under stress. I am Dr. James Whitaker, board-certified urologist with over 22 years of clinical experience in male lower urinary tract dysfunction and pelvic health. I want to be precise about the scope of this video. I am a urologist, and my clinical expertise is in urinary and pelvic function. But the 2 to 4 a.m. waking phenomenon involves systems that extend beyond urology, and I am going to explain the full picture today because my patients deserve to understand the complete biological context of their nighttime symptoms, not just the urinary component in isolation. A patient of mine, Donald, 71 years old, a retired attorney, came to see me specifically because he had read about the connection between 2 a.m. waking and cortisol dysregulation, and he wanted a urological opinion on whether his bladder was the true cause of his nightly awakenings or whether something else was happening. Donald was waking up every night between 2:15 and 3:30 a.m. He would go to the bathroom, producing a small amount of urine, never a full void, and then lie awake for 45 minutes to an hour before falling back to sleep. He described the awakening as jarring, not a gentle transition from sleep, but an abrupt, almost anxious alertness, accompanied by a racing heart and a sense of unease that he could not explain. His bladder never felt genuinely full. He had been told by 2 previous physicians that his nocturia was due to BPH and prescribed tamsulosin, which had not changed the pattern at all. He knew something else was driving it. Donald was right. His bladder was not the primary issue. What was happening to Donald between 2 and 4 a.m. was a dysregulated stress hormone surge, a phenomenon that is increasingly recognized in sleep medicine and endocrinology as one of the most common and most underdiagnosed causes of middle-of-the-night insomnia in men over 60. Let me explain exactly what happens in the body during this specific time window and why it produces the symptom pattern Donald was experiencing. Cortisol, the primary stress hormone produced by the adrenal glands, follows a precise 24-hour rhythm in healthy adults. It reaches its lowest point at approximately midnight, then begins rising steadily through the night, reaching its peak in the early morning hours around 7 to 8 a.m. This rising cortisol wave in the second half of the night serves an important biological purpose. It mobilizes glucose, activates the immune system, raises body temperature, and prepares the body for waking activity. In healthy individuals with a well-regulated HPA axis, hypothalamic pituitary adrenal axis, the system that controls cortisol production, this rise is gradual and does not produce conscious awakening until the natural wake time. But in men over 60 who are experiencing HPA axis dysregulation, which is extremely common and is driven by chronic stress, poor sleep quality, sleep apnea, insulin resistance, excessive alcohol consumption, and the age-related changes in cortisol feedback sensitivity, the cortisol rise that should be gradual instead occurs as a sharp spike. This cortisol spike happens precisely between 2 and 4 a.m. because this is when the HPA axis begins its preparatory activation. When the spike is sharp rather than gradual, cortisol floods the system while the brain is still in deep sleep, creating an abrupt arousal. The sympathetic nervous system activates, heart rate increases, blood pressure elevates, and the man goes from deep sleep to wide awake in seconds. The bladder, which has been filling during the sleep period and is now perhaps at 40 to 50% capacity, not genuinely full but detectable, becomes the focus of attention in the absence of other occupying stimuli, and the man interprets the arousal as a urinary urgency signal, even though the bladder volume does not warrant voiding. This is why tamsulosin, which treats BPH-related obstruction, did nothing for Donald. His bladder was not obstructed. His prostate was moderately enlarged, but not causing significant obstruction. He was waking up because of a cortisol surge, and the small amount of urine he voided each night was simply the consequence of a partially filled bladder being noticed by a suddenly wide-awake and alert brain. The connection between cortisol dysregulation and nighttime waking in the 2 to 4 a.m. window has been studied in sleep medicine research with increasing specificity. A 2007 study published in Psychoneuroendocrinology found that adults with elevated nighttime cortisol, measured through 24-hour urinary cortisol profiles, had significantly higher rates of nocturnal awakening between midnight and 4 a.m. compared to adults with normal cortisol rhythm. The researchers specifically identified the 2 to 4 a.m. window as the peak period for cortisol-driven awakenings. A 2015 study in the Journal of Clinical Sleep Medicine found that men over 60 with HPA axis hyperreactivity, an exaggerated cortisol response to minor stressors, had nearly triple the rate of middle-of-the-night insomnia compared to age-matched controls with normal HPA reactivity. But cortisol dysregulation is not the only warning signal that the 2 to 4 a.m. waking window may represent. There are 4 other physiologically significant processes that preferentially produce symptoms in this specific time window, and each of them warrants attention. The first is hypoglycemia, low blood glucose. In men over 60 who are taking certain diabetes medications, particularly sulfonylureas or insulin, blood glucose can drop to symptomatic levels during the overnight fasting period, with the nadir typically occurring between 2 and 4 a.m. Reactive hypoglycemia, the blood sugar drop that follows the insulin spike from a high-carbohydrate dinner, commonly hits its lowest point approximately 4 to 6 hours after the evening meal, which for a man who eats dinner at 7 or 8 p.m. places the glucose nadir squarely in the 1 to 3 a.m. window. The brain, which runs almost exclusively on glucose, responds to hypoglycemia by activating the sympathetic nervous system and releasing counter-regulatory hormones including glucagon, adrenaline, and cortisol, producing the abrupt, anxious awakening, racing heart, sweating, and sense of unease that many men experience. The man goes to the bathroom because he is awake and his bladder is noticed, not because the bladder is the cause of the awakening. If you are on diabetes medication and experiencing this pattern, ask your physician specifically about overnight hypoglycemia and request a continuous glucose monitor to document whether your glucose is dropping during the night. The second is cardiovascular ischemia, reduced blood flow to the heart, that preferentially occurs in the early morning hours. Cardiovascular physiology undergoes significant changes between 2 a.m. and 8 a.m. Blood pressure rises as cortisol and catecholamines increase, platelet aggregability increases, and fibrinolysis, the clot-dissolving mechanism, is at its lowest activity. This is why the majority of myocardial infarctions and strokes occur between 6 a.m. and noon, but the prodromal symptoms, the warning signs that precede an acute event, can manifest hours earlier, during the 2 to 4 a.m. window when the cardiovascular stress is building. Men who wake in the 2 to 4 a.m. window with nocturnal chest discomfort, jaw or neck pain, unusual breathlessness, or profuse unexplained sweating should seek urgent cardiac evaluation. These symptoms in this time window are not reassuring coincidences. The third is sleep apnea events clustering in REM sleep. As I explained in an earlier video, obstructive sleep apnea involves repeated breathing obstructions during sleep. REM sleep, rapid eye movement sleep, the dream stage, produces the deepest relaxation of the upper airway musculature and is therefore the stage in which the most severe and most prolonged apnea events tend to occur. REM sleep is most abundant in the second half of the night, between approximately 2 a.m. and 6 a.m. Men with undiagnosed or undertreated sleep apnea therefore experience their most disruptive apnea events, the ones that cause the most severe oxygen desaturation and the most violent sympathetic arousals, in the 2 to 4 a.m. period. Each arousal produces a cortisol spike, a sympathetic activation, and a sudden awareness of the bladder, which may have been filling for several hours and is now noticeable. The man voids a moderate amount, returns to bed, and the cycle begins again within 90 minutes. If this pattern describes your experience, please be evaluated for sleep apnea before your next urology appointment. The fourth warning signal that can manifest as 2 to 4 a.m. waking is atrial natriuretic peptide release secondary to cardiac strain. I described this mechanism in the context of sleep apnea, but it is worth noting independently. Any condition that increases right atrial stretch, including early heart failure, pulmonary hypertension, or severe sleep apnea, causes ANP release that drives nocturnal urine production. If you are waking between 2 and 4 a.m. with a genuinely full bladder, not just a slightly full bladder noticed in the context of anxiety, but a truly urgent, large volume void, and this is happening despite careful fluid restriction, cardiac evaluation, including an echocardiogram, is appropriate to rule out subclinical cardiac dysfunction. So what should you do with this information? The first step is to keep a detailed sleep and voiding diary for 2 weeks. Record not just the time you wake up and whether you voided, but the nature of the awakening. Was it a gradual, gentle waking or an abrupt, anxious alertness? Was there a racing heartbeat, sweating, a sense of anxiety or unease? How full did your bladder actually feel? Did the void produce a large amount or a small amount of urine? This information is diagnostically invaluable and will direct your physician toward the correct underlying mechanism far more efficiently than any questionnaire. The second step is to discuss with your physician whether a salivary cortisol awakening response test, measuring cortisol at the time of your nighttime awakening compared to your morning baseline, would be informative for identifying HPA axis dysregulation as a contributor to your 2 a.m. waking pattern. The third step is to address the most modifiable drivers of cortisol dysregulation. Alcohol elimination after 6 p.m., consistent sleep and wake time 7 days per week, morning light exposure within 15 minutes of waking to reset the circadian cortisol rhythm, stress reduction practices including diaphragmatic breathing before bed, and discussion with your physician about adaptogenic supplementation, including ashwagandha, which has been shown in multiple randomized controlled trials to reduce cortisol levels and improve sleep quality in middle-aged and older adults. Donald's outcome, after we correctly identified the cortisol dysregulation as the primary driver of his 2 to 4 a.m. waking, was a dramatic improvement within 8 weeks of implementing these interventions, combined with a structured stress reduction program and the elimination of his 2 nightly glasses of wine. He has not taken tamsulosin in 6 months. He wakes up once or twice per week between 2 and 4 a.m. now, compared to every single night. His energy has recovered. His daytime functioning has returned to normal. His bladder, which was never the true problem, is perfectly well. Your nighttime waking is information. It is your body communicating something specific. Learn to read that information correctly, and you can address the true cause rather than masking a symptom while the underlying condition progresses unchecked. Share this video. Leave a comment below telling me what time you typically wake up and what the awakening feels like. Like and subscribe for weekly urology content. I will see you in the next video.